Hello and welcome to this lesson, polymyositis and dermatomyositis. So dermatomyositis and polymyositis are one of the causes of muscle weakness, and because of the fact that we have a very broad differential in these two diseases, you have to be very careful if you are being asked about this disease or other diseases that can mimic signs and symptoms of polymyositis and dermatomyositis. So first of all, what is polymyositis and what is dermatomyositis? First of all, note that this is a T-cell mediated autoimmune disease, and it affects skeletal muscles, and the muscles that are being affected are proximal muscles of lower extremity as well as upper extremity, and also we can have involvement of muscle of the neck. So in this disease you are going to have muscle weakness due to the fact that the muscle is inflamed due to T-cell mediated autoimmune disease, and also you are going to have inflammatory infiltration of skeletal muscles. Cardiac muscles and smooth muscles are spared in this disease, and also truncal muscles are also going to be spared, so you are not going to see any form of inflammation and weakness in truncal muscles. Another point is that dermatomyositis also has signs and symptoms of polymyositis with addition to dermatological manifestations. And also note that in case of dermatomyositis, we are positive for two antibodies, anti-M2 antibody and anti-Jo antibody. So in the dermatomyositis, we have polymyositis plus dermatological signs. So first, let's talk about common presentation of polymyositis and dermatomyositis. So in case of these two diseases, you are going to have progressive muscle weakness, and it can take from weeks to months to develop. But note that you can also have a sudden onset of the disease. So if you are going to have, if the patient is going to have a sudden muscle weakness, this does not exclude the diagnosis of polymyositis and dermatomyositis. Also note that the muscles that are involved in case of polymyositis and dermatomyositis are proximal muscles of the upper and lower extremity, and also muscles of the neck can be involved in this disease. So this gives the patient the presentation with something like difficulties raising from the chair or climbing stairs. Raising from chair needs proximal upper extremity muscles, and climbing stairs needs muscles of the foot, which are proximal lower muscles. So another manifestation is that patient can also have dysphagia, and this is due to the fact that the skeletal muscles of the upper pharynx can be inflamed in case of dermatomyositis and polymyositis, which gives the patient problem with initiating the swallowing of the food. But note that the ocular and facial muscles are going to be spared, and this is unlike the myasthenia gravis, which gives the presentation of ptosis and also facial muscle weakness. So this is a very important difference between dermatomyositis, polymyositis with myasthenia gravis. Another point is that the patient can also have problem with respiratory muscles, which causes hypoventilation, CO2 retention, and as the result, the patient will have respiratory acidosis, and if the problem is severe enough, the patient can also have respiratory failure. So now let's talk about presentations that are specific for dermatomyositis and are absent in case of polymyositis. So first of all, we have Schall sign, and this is an erythema over upper chest and back. So it's like someone is having burning signs on the places that are covered by the Schall. So we call it Schall sign. We can also have Gatron papules on the hand. So these are the raised lesion in the MCP, PIP, and DIP joints. So distal interphalangeal joints, proximal interphalangeal joints, and also metacarpopharyngeal joints. And note that plus the fact that the patient might have a raised lesion in the dorsal surface, they can also have erythematous rash on the extensor surface of the hand. And another important point about dermatomyositis is that the cutaneous findings are going to appear before appearance of muscle inflammation symptoms. So the patient will have Schall sign, Gatron papules before developing muscle weakness in case of dermatomyositis. So now let's talk about findings in case of dermatomyositis and polymyositis. First of all, note that we are going to have increasing amount of creatine kinase and aldolase enzyme, and elevation in these two enzymes is also reflective of how advanced the disease is and how advanced is the disease activity. So the higher the creatine kinase and the higher the aldolase enzyme is, it means that we are going to have more severe disease. And also the patient may have elevated ALT and AST, but note that these enzymes are not going from liver. These are the muscle-derived ALT and AST. And as the result, the clinical finding can be mistaken with a case of hepatitis. But our general inflammatory markers, CRP, C-reactive protein, and ESR are going to be normal in most of cases. If the patient has an MRI, on the MRI you are going to see patchy involvement of the muscles. So this is an MRI of a patient who is suffering from polymyositis, and you are seeing some patchy infiltration of the muscles. So these are very specific for dermatomyositis and polymyositis. And also MRI can guide the biopsy, which is the gold standard for establishment of diagnosis of polymyositis and dermatomyositis. So with the help of MRI, you are not going to biopsy, for example, somewhere around here. You are going to biopsy this area which is affected and has muscle inflammation. So with biopsy, you are going to establish the diagnosis, and also note that the muscle biopsy is gold standard for diagnosis of these two diseases. So now let's talk about differential diagnosis, and this is actually very important for you to know because in board examinations you are going to have many questions, patients who are presenting with either muscle weakness or muscle pain. So you have to know the difference between polymyositis and other diseases that can mimic the signs and symptoms of polymyositis. So from systemic inflammatory diseases, the lupus, Sjogren's syndrome, and systemic sclerosis can also cause muscle inflammation. So if you are suspecting these diseases, you have to search for other symptoms that are belong to these diseases. For example, in case of SLE or in case of Sjogren, patient may also have xerostomia and xerophthalmia. In case of hypothyroidism, the patient can also have muscle weakness, but this is not due to the fact that the patient is suffering from muscle inflammation and muscle infiltration. This is due to the fact that the thyroid hormones are producing less. But in case of hypothyroidism, the patient can also have increased creatine kinase. So TSH and T4 are actually indicated for diagnosis of hypothyroidism and making the differential diagnosis from polymyositis and dermatomyositis. So another differential is hyperthyroidism and Cushing syndrome, because these two diseases also give proximal muscle weakness. But in case of hyperthyroidism and Cushing syndrome, the creatine kinase level is going to be normal. Another important diagnosis, differential diagnosis, is polymyalgia rheumatica. And note that the difference between polymyalgia rheumatica and polymyositis is the fact that in case of polymyositis, the patient is going to be suffering from muscle weakness, but in case of polymyalgia rheumatica, the patient is going to have muscle pain, and patient is usually more than 50 years of age, and there is no weakness in case of polymyalgia rheumatica. Another disease is ALS and myasthenia gravis and Lambert-Eaton syndrome. All of these diseases can cause muscle weakness. For example, in case of myasthenia gravis, it's because of an autoimmune process. Lambert-Eaton syndrome is one of the complications of lung neoplasia. But in case of ALS, myasthenia gravis, and Lambert-Eaton syndrome, you are going to see neurological symptoms as well. For example, in case of myasthenia gravis, the patient will have ocular symptom, ptosis, and facial weakness. So you have to know the differences. When you have muscle weakness, you have to search for other symptoms and signs in patients in order to make the differential diagnosis. So another differential is when a patient is administered for a long-term use of corticosteroids, because corticosteroids can also cause muscle weakness. But here again, we have usually normal creatine kinase. Corticosteroids in long term can cause diabetes mellitus, can also cause Cushing syndrome. So note that these are the difference between polymyositis and dermatomyositis and long-term usage of corticosteroids, and also statins. Statins can also cause myopathy and rhabdomyolysis, leading to muscle weakness. So know the differentials, because sometimes a patient who is presenting with muscle weakness can have other signs and symptoms, and that signs and symptoms can help you to make a very good differential diagnosis. So now let's talk about treatment of polymyositis and dermatomyositis. So most patients are going to respond to corticosteroids very well, and in order to control the disease activity and progression, you need to have long-term administrations of corticosteroids. But if the patient should be reduced with corticosteroid level, we have other options as well. So methotrexate, azathioprine, and mycophenolate, all of them are immunomodulator drugs, and if you need to decrease the amount of corticosteroid that administered for the patient, you can use these alternatives. Also, we have IV immunoglobulin in case of dermatomyositis. This is an FDA approved drug for case of dermatomyositis, and also rituximab, which is a monoclonal antibody drug against CD20, and this is usually saved for patients who are resistant to treatment with corticosteroids, and it's usually used for dermatomyositis. So thank you for watching. See you in the next video.